All right, good afternoon, guys. Everybody doing okay? Hit those cameras on for me. We are going to, I'm kind of going out of order of how it's listed in the content. And today we're going to talk about chapter 8, which is orthopedic and neurological impairment, because that kind of plays along the same lines of what we've been talking about with intellectual disabilities and mental disabilities like we talked about in the prior two classes. So we're going to go ahead and stick with some other things that are kind of along that same line. So we're going to go chapter 8. Your brilliant instructor, I got a little cold. It's not the Rona, it's just a cold. So I stopped on the way to work today. Ran in Dollar General to grab some cough medicine to try to clear my throat out, and I got the nighttime cough medicine. So if I look a little drowsy, it's because I am. So anyway, we're gonna get through this. Let me go ahead and just share screen, and we'll get started. Run through this stuff. Hopefully, we'll get done a little early if things go to plan. So let me share my screen. All right, like I say, we're going to talk about both orthopedic and neurological impairments today. And a big portion of what we're talking about is trying to get our patients back to be able to re-enter the community. So we're looking at community reentry. We're giving them skills to use when they get out of our care as a recreation therapist. As far as the learning objectives, like I say, we're going to hit on orthopedic, which is skeletal system basically, and neurological, which is going to be our nervous system. Conditions that people can have that can be served by therapeutic recreation practitioners. We'll also talk about what role therapeutic recreation plays in providing services to people with those conditions. We'll talk about what modalities, or again, that's just tools that we use to address these conditions in rehabilitation settings and in reintegration, trying to get them back into the community. And we'll talk about, appropriate application of these tools, when we should use them, things like that as we go through. So when we're looking at physical rehabilitation programs, we are, what they're for is they are here to address disturbances or deterioration of physiological functions. And these impairments, they can affect any and all areas of function. About 16% of CTRSs, I would say it's probably a little higher than that since this slide was put together, work in rehabilitation. So it's a fairly common area of work. As far as the role of TR specialists within the rehabilitation setting, we're just trying to give programs that can impact areas of function. A lot of times they've lost the ability to care for themselves, to be able to speak, communicate, understand spoken words, a lot of different areas of daily skills that they lose. So those are some things that we touch on. We also work on trying to teach them the skills that they need to be able to participate in recreation in the future once they're out of our care. So the two groups, like I said, we're going to talk about orthopedic and neurological. Orthopedic impairments, obviously know the difference between orthopedic impairments and neurological impairments. That will be a key. I'm sure that will be on the test at some point. orthopedic impairments are just caused by disruptions of skeletal muscle system. So we're talking about, torn hamstrings, ACL injuries, problems with the spine, arthritis, sprained ankles. There's two different types of arthritis. The first is osteoarthritis, and that's the one that is caused by overuse, or, it usually happens when people get a little older. If you've played football your whole life and you've had knee injury or something like that, you're going to be more prone to getting osteoarthritis. This is the overuse type. A second type is rheumatoid arthritis, which is, it's an autoimmune activity arthritis, and it affects, it kind of comes and goes, and it can go to different joints causing pain. Those are the two main types of arthritis. Some other things are degenerative bone diseases, osteoporosis, severe fractures, soft tissue injuries, like I said, like a hamstring tear, ankle sprains. And then we also work a lot with limb amputations, which is actually a very interesting group to work with. They've got some things going on that, the normal population does not, per se. Get to see some really cool prosthetic devices. Sometimes I'm sure you guys have seen videos and things, and I kind of meant to get in and add one showing some prosthetics that are cool, that fit with recreation. In Special Olympics, there are people that are running that have, I think they call them blades. It's the springy looking legs that are used for racing. There's those type. There's the type that actually look like a real limb that are there. As far as therapy for them, we deal with something called phantom pain. Once somebody has a limb amputated, they tend to have pain where that limb was, or they feel the pain where that limb used to be, which is a very strange phenomenon, but it eventually gets better. So that's something that we can kind of address, phantom pain. We work on mastery of ADLs, which are activities of daily living, which is just your basic, being able to walk, being able to get in and out of a vehicle, being able to go upstairs, things like that. And we work on mastering recreation and leisure skills. As far as neurological impairments, we're talking about injuries that originate in the nervous system. So know that that's what a neurological impairment is. Sometimes neurological impairments are classified as orthopedic, although they can kind of be both, because the reason that happens is because they a lot of times impact the ability to use the skeletal muscle system. So like you talk about a spinal cord injury here below, that causes, issues below the site of the injury. So obviously it's going to impact them orthopedically as well as neurologically. So what they're going to see is disturbances in their motor control, their sensation or lack of, or both. And the location and severity of the injury determines the nature of disability. So something here else to note and know the difference is paraplegia and quadriplegia. In paraplegia, you're talking about someone in most cases who have lost the function of their legs, but they still have function in their arms. Quadriplegia, all four limbs are affected. In some cases, there is hemiplegia, where one side of the body is affected and not the other. So be sure to know the difference between these. And there can also be complete and incomplete injuries when it comes to neurological impairments that deal with the spinal cord. A complete injury is going to be, a rupture to the point where you lose function and you're unable to move the body parts below the area of the injury. That once that break in the chain happens, nothing can get there as far as nerve signals. The communication is broken down. Incomplete injury, those are the ones where people can rehabilitate, can learn to walk again in cases, things like that. But it's a long road usually when there's an incomplete injury. Traumatic brain injury is another type of neurological impairment. It's going to impact a lot of different levels of functioning. And what has to be taken with traumatic brain injury is a comprehensive approach, as stated here. There's wide ranges of severity that have to do with this. Usually what happens is, a traumatic brain injury, obviously, even though we have our skull to protect our brain, there is either an open, penetrating, or a closed injury to the brain. Like penetrating, say a limb fell out of a tree and stuck in someone's head, or a gunshot, something like that can cause a penetrating TBI. A closed injury is going to be where you actually don't have anything enter the brain, but there's still damage to the brain that causes issues. A lot of times there's swelling that plays a role, and when they put people in medically induced comas, a lot of times they're trying to get rid of swelling, give their brain a chance to heal while they're not moving and trying to understand even what's going on. Traumatic brain injury is not degenerative. It doesn't really get worse. The damage that is caused is just the damage that will be there. And it's not congenital. It's nothing that has to do with birth necessarily. Something that they go by when they're trying to, and we're not going to go deep into this because this is something that we would not really use as a recreation therapist, is this Glasgow coma scale. It kind of shows what level of brain activity is going on with patients who have TBI. People who have traumatic brain injury are unpredictable, to say the least. They have trouble. One of the main things they have trouble with is aggression, just kind of out of the blue. Inappropriate responses to, they may be at a funeral and just bust out laughing. It's not that they're trying to be, not respectful. Their brain injury causes these changes in their affect and how they act. So that's something to kind of deal with traumatic brain injuries. Some other neurological impairments: cerebral vascular accidents, CVAs. The main one that comes to mind is a stroke. We've talked about before, I'm sure you've all known someone or heard of someone who had a stroke. Blood flow is interrupted to the brain, and there's some damage that occurs because of that. Usually with a stroke, it's going to affect one side or the other of the body. You'll see someone, their face will start drooping, they'll start becoming less responsive, things like that. Aneurysms are another type of CVA that's generally caused by a blood clot that will all of a sudden break free from somewhere and block flow. Multi-infarct dementia. It is dementia that's brought on by blood flow restriction to the brain. And then there's transient ischemic attacks, TIAs, and basically those are kind of like mini strokes. They are not, generally people can come back from this easier. They may be short lived. You have a lot of the symptoms of a stroke, but by the time you leave the hospital, they may be gone. It's a good indicator that you are a very good candidate for a real deal stroke, though. Consequences of these CVAs, you've got, left brain versus right brain stroke. Depending on which side of the body of the brain that is affected, that's going to matter on which side of the body is affected with your symptoms. So if you have a stroke on the left side of your brain, it's usually the right side of the body that is affected, which is interesting in its own right, and just the opposite for a right brain stroke. Hemiplegia, like I talked about a little while ago, this is common with CVAs and incidents that have to do with the brain, because one side is affected, so it's going to affect one side of the body. It's usually going to be on one side or the other where you have the blood loss to the brain, and it causes these things. So hemiplegia, no effect on one leg and one arm, face, everything on one side is generally going to be pretty normal. The other side can be all the way from unable to use it to, just having some difficulties with movements, things like that. It's not total hemiplegia where they can't use one side of their body. That's where you see like a droop in a stroke patient on one side of the body. That's going to be the same side that they will have issues with their arms, legs, and movements that they're trying to do. Another thing we see is aphasia. Aphasia is basically just a loss of ability to understand speech, and a lot of times to express speech. You need to know what aphasia is. Another thing is dysarthria. It can happen as a consequence of CVAs, and that's basically the weakness of muscles that are going to be used for speech. What that turns into a lot of times is distorted speech that's hard to understand, very slow speech, because the muscles that they're trying to use to speak are weak because of damage that has been done. So aphasia, you definitely need to know that. Hemiplegia, know what a TIA is. Obviously know what a stroke is and some of the symptoms of that. Some other conditions that can be seen in rehabilitation settings, which that's where we're talking about a lot of, 16% of recreation therapists work in rehab settings. And, a lot of people, this would be a setting that they would enjoy. They would get to see a lot of different patients, a lot of different issues going on that they're all dealing with. Once they're you get to see people get better and leave, and that makes you feel good about yourself when you've done something. You see someone improve, and then they're able to be discharged. So that's a good setting for a lot of people. Really like rehabilitation. Parkinson's disease is served in rehabilitation settings. A lot of times Parkinson's is, people begin shaking. They have trouble with, when they start out, they start having some tremors in their hands, usually jerky movements. It's progressive. So what we can do as recreation therapists with Parkinson's is to try to maintain where they are and not let them keep getting worse. We're not going to really undo and take away hand tremors or make them walk a ton better. But if we do activities with them and work with them, once they're to the point where they're having issues with walking and locomotion, then we can try to at least keep them where they are as long as we can and prolong the good time that they have. Guillain-Barré syndrome is another. I won't test you on that. There's cardiovascular conditions that are also present in rehab settings, and pulmonary conditions. So as far as the common therapeutic recreation modalities that we see in a rehabilitation setting, we use recreation for both physical and cognitive rehabilitation. Physical rehabilitation, exercise, everyday skills like walking up and down stairs. Cognitive rehabilitation would be things like, we'll go back to the dominoes we've used before. They are working on matching, they're working on keeping score of the game, and, card games, they're having to think. Bingo even, where they have to actually look and remember, what B7 is and find it. For someone who's heavily affected, then that may be the level of cognitive rehabilitation that can be done with them. But we can do activities. Arts and crafts can be a form of cognitive rehabilitation where they're working on both physical and cognitive by the physical fine motor skills of making art, and the cognitive side of when it's done and you are debriefing, you ask, okay, well, tell me what your painting means, and you get them to express what they're thinking about. So you're working on cognitive issues there as well. Some things that are used: sensory stimulation for people who've had their senses dulled by issues that have hurt them neurologically. There are things, sensory stimulation rooms, where there may be different sounds, different lights, flashing lights, different temperatures, all sorts of different senses can be affected and touched on in a sensory stimulation environment. Pain management and relaxation, those are two very good things. Aquatic therapy is a very viable choice in a rehabilitation setting. One main reason is that, aquatic therapy takes a lot of the weight off of people. If they have trouble with walking or balance, it's going to help with that. If they have trouble moving one side of the body, it's easier for them to move it in the water because the limb is lighter. Animal assisted therapy, that helps a lot with, say TBI, someone who has some damage to their brain that has caused them to, their expressions are kind of dulled from this. Animal assisted therapy, they're having fun, they are interacting. That's one type. You've also got hippotherapy, which we've talked about. Horse therapy, where you're just spending time working with the animals more for fun than for actual rehabilitation. Hippotherapy is where you ride the horses to try to get the benefits of the movement of the horse. You're working on trunk control and things like that. And also horticulture therapy, where they're working on plants, planting things, picking, things like that. Kind of trick people into exercising, bending, grasping. It also gives them a sense of purpose, and something that a lot of patients look forward to on, every day. They want to go out and check their plants and see how they're looking, Oh, I got to go water my plants. So that gives them a sense of direction and a sense of purpose to their day as far as horticulture therapy goes. Community reintegration. This is big and something that is key in today's society. There's been cuts to funding for mental health, rehabilitation, all those sorts of things. And there's been a push for, quote, deinstitutionalization, which, you know, they don't really, I say they, government entities, are looking for people to be integrated into the community if they're at all able to. And that goes along with the least restrictive environment that we've talked about before as well. So community reintegration is a big part of deinstitutionalization. What we want to do is get them ready to integrate back into society by giving them things that are under this leisure education tab here. Leisure awareness. What do they have available to them to do? You know, what are some, you may teach them some games, some activities that they would enjoy doing when they are not in your care anymore. Leisure resources, you're sharing with them the things that they can have available to them when they're not in your care. You know, hey, you may want to keep up with the park commission page. They have a lot of activities here. Here's the website for them. I want you to check this. You know, you're giving them resources. Social skills, we work on that, especially with, you know, like I say, the TBI, traumatic brain injury, they have issues with social skills. And the ones who are affected, who now don't, you know, are used to be able to walk. Now they've been in a car accident and they're in a wheelchair. Do you think they're as actively looking to be social as they once were? Probably not. They're probably depressed. So we want to work on social skills and getting them to be comfortable with socializing with other people, integrated. Activity skills, you know, this is once we've shown them and talked about things that they would like to do as far as leisure and recreation. Once they leave, we can help them learn the skills that it takes to do the activity. So, I mean, we might teach them how to play bocce. And I don't know how many of you have heard of bocce. It's you roll out a little ball and then you have to roll another ball and try to get it close to it. It's in a similar scope to horseshoes or something like that almost. Or curling, if you've ever seen that in the Winter Olympics. You're trying to get yours closest to the smallest ball. Once you've told them about that, if that's something that they enjoy, then you can spend some time as a recreation therapist helping them to practice that skill where they will be better at it and enjoy it more once they're able to move out into the community. And then community-based services, there are kind of outpatient recreation therapy services and rehabilitation services that are offered. We want to, that's a place where you could work, number one. Number two, we want them to be aware and know that community-based services are available once you're no longer here with us. These are some places that you may want to look into, and you could share that information with them as well. As a recreation therapist, you know, part of it is really caring about your patients. And I know I've kind of harped on that, but I truly believe it. And I think that things like that, it will come naturally to you if you do, to want to give them the information they need when they are gone to be able to succeed. So take that little bit of time and make them a list of community-based services that they can use once they're no longer in your facility. Things like that go a long way and help your patients and help you feel good about knowing that you did everything that you could to help them. In this setting, you're going to be working as part of a treatment team, and we've talked about that, and we've talked about team meetings where you have all the different entities sitting around working on the best possible strategies to serve the clientele. And one of the important things is a lot of these facilities have clinical pathways, and basically what clinical pathways are simply is just it's a predictable treatment course that you're going to use and a predictable sequence that you use for people with specific diagnoses. So that being said, it still needs to be individualized for the person, but it gives you a pathway that clinically, this is what we do first when we have a spinal cord injury come to our facility. You know, they're going to be seen by physical therapy. They're going to be seen by the doctor and nursing. They're going to share the information from there to recreation, physical therapy. They're going to start working on rehabilitation. Once they've done that, then they're going to work on daily living skills with the home health. You know, things like that. It's a clinical pathway. This we do A, B, C. The order is the same, but the amount of care and the type of care that you give is going to be different for each individual. Treatment protocols, it's basically the same thing. It's just a certain appropriate protocol to be used for each one of these groups that we've talked about. You follow the protocols that are going to be given to you by the rehabilitation facility that you would be working. And importance, what I have that there for is just talking about the importance of working as a part of a treatment team and realizing that, and this is a big issue with interdisciplinary teams like this. You've got physical therapy, recreation therapy, nursing. Everybody has their own opinions. Everybody has their own expertise. Nobody is more important or smarter than anyone else. You know, theoretically, you're all qualified. You all should be able to work together for the betterment of the client and put a little bit of pride aside at times to make this happen. Because if not, here you are sitting around a table wasting time that clients could be served, bickering because you think what you're wanting to do is more important than somebody else. So communication, importance of that is huge, and being able to compromise and work with the other people that are around that table in that treatment team. And I told you we were going to get done early today. This top one here, be able to differentiate between neurological injury and an orthopedic injury. Think about how and why sometimes neurological injuries are diagnosed as being orthopedic. One thing when you're working in rehabilitation, and it's on this very last bit here, do you think that any of the modalities that we could use have the potential to harm a client if used inappropriately? They could be. Almost anything you do could harm someone if it's used inappropriately or done in an improper way. Just say a sensory stimulation situation. If you're in a sensory room and you've got a laser light show going on and it's hitting someone in the eye over and over, you could have some damage to the eye. I mean, that's just a very bland example, but we have to be careful when we are choosing modalities and know that we know how to do them, you know, the tools that we're going to use, the activities we're going to use. Would you, if you have no example working on a ropes course, want to take a group of clients out to do a ropes course? Absolutely not. You'd have people falling everywhere. So you would be negligent in that case, and because you're not professionally capable of using that particular modality because it's not your scope. If that's your thing and you understand them, then absolutely, that's a perfect thing to use. So as a recreation therapist, you need to constantly be looking to learn as many things as you can, be proficient in as many tools as you can to be able to use a lot of different strategies with our patients, and make sure that you get comfortable with them, get better with them, and that you're able to use them in the proper way to not put anybody in harm's way. That's the kind of important part there. So I'm going to cut y'all loose early today. I know y'all are going to be very upset about that. Let me stop my screen share. Anybody have any questions, anything like that before I cut you loose? All right, y'all have a good day. Next time we will just jump right into another chapter, and we'll keep on trucking along. Caitlin, yes, I did get your message. I got you down. Thank you. You guys have a good day. I'll see y'all next time.
Have a good day.
All righty.